as Dr. Jagoval has already shown the way we should go forward, but then everybody have the doubts in their mind. Is it safe? What are the problems? Of course, when there is polypharmacy, especially powerful drugs in a complex disease like heart failure and reduced ejection fraction, there can be a problem. So these are multiple the trials over the last 3 decades. We have accrued data with multiple trials, multiple drugs, multiple devices. And finally, we could pick 4 ACEs that Dr. Jagoval was telling that these 4 ACEs are ARNI, beta blocker, MRA, and SGLT2 inhibitors, which became the pillars of therapy. So I'll show a case of a 54 years old male anterior volume in 2014. We did a primary angioplasty to LAD at that time, but his LV did not improve. He developed heart failure and reduced ejection fraction. AF progressively, later on he developed CKD, is diabetic also, NYHA class 2 till 1 year ago. Now he developed worsening of heart failure with recurrent admissions. These are the medication. The last admission: beta blocker, MRA, ARNI, SGLT2 inhibitor, vericiguat, aspirin, statin, OHA, and rivaroxaban. And at the time of last admission, that's 1 month ago, his recent admission was with fatigue, dyspnea, pedal edema, blood pressure borderline, heart rate low, pedal edema, bilateral Krebs, grossly elevated JVP, and you can see the heart rate. It is AF with almost something like a what you call very low ventricular rate and broad QRS complex. These are his serial electrolytes. Blood urea start with 151. With treatment, we could reduce it to 99 over a period of almost 3 weeks. And the creatinine at the time of admission, it was 7.38, which was 1.7 or 1.8 before the admission. This acute kidney injury, but there is a prevailing CKD. We could stabilize him to 2.373. 37, sodium 127 to 134, and potassium from 7.6 to 4.3. So this is the trajectory of heart failure with reduced ejection fraction and the treatment. It's a progressive disease. It stabilizes the underlying that stability, which is a clinical symptom stability. The heart failure progresses because of the apoptosis and the fibrosis going on. So they stabilize, deteriorates, stabilize, deteriorates, and finally will start deteriorating and will end up in LVAD or a mechanical cardiac support device, or finally transplantation. And in between, these are the problems that we come across: hypotension, hyperkalemia, renal dysfunction, and arrhythmias. So this guy, finally, I discharged him on 2310. No much guideline recommended medication: twice-imide, isoleucine or isosorbide dinitrate plus hydralazine, vericiguat, warfarin, and linagliptan. So now I'll be calling him back and then see whether I can restart him on the guideline recommended medical therapy. So there are problems with treatment. If you look at the earliest study, the carvedilol, which was the first, the US carvedilol study, they showed us the benefit of beta blocker, and later on we got that benefit from bisoprolol as well as from the metoprolol succinate. So if you look at it, what are the major adverse effects with carvedilol in a very sick group of patients? It was predominantly fatigue, not fatigue, it was bradycardia, which was in 0.9%, and then dizziness. Hypotension was not that great, and syncope was not great, and then other things were not significant. So dizziness and bradycardia were the most important side effects. And with the spironolactone, it was gynecomastia or painful gynecomastia or a breast pain in males, 10%. Serious hyperkalemia, 2%. And the drug discontinuation rate was only 8% versus 5% in the placebo. But these early trials, this was not with the 4 drugs on board. It was the ACE inhibitors were there in the carvedilol trial, and this drug had beta blocker and ACE inhibitors. And we'll come to the most important drug, that is ARNI, which showed the best outcome benefit in heart failure and reduced ejection fraction. Symptomatic hypotension in 14%, impaired renal function in 5%, hyperkalemia in 12%, angioedema in 0.5%. And symptomatic hypotension was the statistically significant thing which was different from the placebo: 14% in the vericiguat and 9.2% in the enalaprilam. and blood pressure of less than 90, 2.7% and 1.4%, and the reason for discontinuation of drug only in 0.9%. And if you look at the elevation of creatinine, more than 2.5 or more than 3, elevation of potassium, these were more with enalapril rather than with ARNI. And action taken, mostly dose adjustment in 50% of patients or a temporary interruption. And the permanent discontinuation was 3.3% for the sacubitril valsartan when you look at the side effect signals. And change in concomitant medications 12.4%, non-drug therapy 2.6%, and adverse effect leading to hospitalization was 7.4% in the ARNI arm. So, majority of these problems could be managed with change in the concomitant medication and other non-drug therapies, and discontinuation was required only in 3.3%. So, in the Pioneer HF, which was the most sick patients, acute heart failure admitted, and ARNI was tried for the first time. In the Paradigm HF, it was chronic ambulatory patients with heart failure and reduced ejection fraction. They are stable patients. Here, worsening of renal function, hyperkalemia, symptomatic hypotension, and angioedema were not significantly different from the enalapril. And record of down titration or discontinuation of the RAS inhibitors therapy due to hyperkalemia is so small. So, adverse effects do occur, but not as great as what we think, and many of them are manageable. So, hypotension, you look at whether there are other drugs that can interfere with the concomitant medications, calcium channel blocker, alpha blocker, nitrates. Remove it. They are not going to help in heart failure except nitrates in certain situations. Diuretics, if possible, reduce it. And if not possible to continue the sacubitril valsartan in that particular dose, reduce the dose of sacubitril valsartan. Renal impairment, look for hypovolemia, intravascular volume depletion, correct it. Adjust the dose of diuretics and sacubitril valsartan. But if there is a serial increase in the creatinine, it goes more than 50% from the baseline. If it goes above 3 mg per deciliter with the treatment, then you may have to discontinue sacubitril valsartan, then may wait and reintroduce. Hyperkalemia, look at mineralocorticoid receptor antagonist, reduce its dose, and if needed, stop it. Then try to continue sacubitril valsartan, but if it doesn't permit, you can wait up to 5.6 millimoles per liter, and if it goes above, then we may have to stop it. This was also shown by Dr. Jayagopal. Don't worry, if you are reducing from 100 to 50, that dose also gives some benefit. May not be the benefit as a 200 milligram twice a day can give, but some benefit is always better than no benefit. So, something is better than nothing. There is no need to worry about reducing if it required. Dapagliflozin, there is no significant difference in the side effect profile. The event rate was only 9% with the dapagliflozin, and the major difference that was seen with dapagliflozin is only one thing, an increase or excess of genital mycotic infection. So, other things, volume depletion, renal adverse event, fractures, amputation, major hypoglycemia, even in patients who are non-diabetics, no difference. No difference in adverse events leading to treatment discontinuation, and no much, actually any serious adverse event was lesser in the dapagliflozin. So, 4 pillars of therapy, it's reasonably tolerated drugs. Adverse effects can be managed. So, what are the serious issues which requires drug discontinuation? Symptomatic hypotension, that is a major problem with ARNI. Hyperkalemia, renal dysfunction, bradyarrhythmia or severe bradycardia. And in symptomatic hypotension, the most important agent is the vasodilator, ACE inhibitor, ARB or ARNI. Look at the volume. If there is volume depletion, correct it. That most important concomitant problem that leads to hypotension is volume depletion. Look at the postural fall in blood pressure, that is important. And diuretic dose, you keep the minimum dose of diuretic to reduce the congestion. Clinically, by looking at the JVP, edema, or you can use the ultrasound and look for the lung comets, look at the NT-proBNP, whether it is coming down or not. If the NT-proBNP is not coming to less than 1000 millipicogram per ml with your treatment, this patient is going to do bad. And look for any non-heart failure drugs which is causing hypotension, like a diltiazem, a verapamil, a calcium channel blocker, even amiodarone. And change carvedilol, Dr. Jayagopal was also telling. If you are not able to push the dose of ARNI or continue that dose of ARNI, look at your beta blocker, is it carvedilol? If it is carvedilol, which has an alpha blocking action, change it over to another beta blocker like a nebivolol, bisoprolol, or even a metoprolol succinate. It may help. And then, if not possible, patient develop postural hypotension, patient is symptomatic, reduce the dose of the drug. Then patient walk into your OPD, he is doing all his regular activities, he is not symptomatic, his blood pressure is 90. What will you do? If his renal function is stable, if his volume status is stable, there is no evidence of postural hypotension, and the patient is absolutely okay. There are a lot of patients, everybody who is treating high heart failure may be seeing on ARNI, blood pressure 90 or blood pressure 87 or 88, patient is absolutely asymptomatic, no need to touch that ARNI because discontinuation may create a problem. The cutoffs you should have in mind, systolic blood pressure, usual cutoff is 100 millimeters of mercury to start the ARNI, and there should not be any postural fall of more than 20 millimeters of mercury. Potassium cutoff limit is 5.4. You may go up to 5.6. Nephrologists feel that even up to 5.8. Okay, watch. EGFR is 20 for the SGLT2 inhibitors and 30 for the ARNI. But now, an off-label relaxation is a practicality. Even those patients who are on renal replacement therapy, most of the nephrologists feels that to derive the cardiovascular benefit, you may continue the SGLT2 inhibitors, and for that matter, if the hyperkalemia is not a problem, you can even continue the ARNI. But I always discontinue the ARNI if the EGFR is less than 30 and SGLT2 inhibitors if the EGFR is less than 20. The initial fall in GFR is a hemodynamic effect. Don't worry about it, it will fall. But it should not fall by more than 10 and should be more than 25 ml per 1.73 per meter square body surface area, EGFR. Serum creatinine may go up to 50% from baseline, provided the absolute value should be less than 3 milligram per deciliter. So it is not a very tight compartment. You can relax, but only thing is you have to keep the patient under strict surveillance. Hyperkalemia, mostly if you combine the RAS inhibitors or ARNI with MRA. So, and it is found that if you start the ARNI first, later on all the MRA, usually the MRA is well tolerated. And also in patients with renal dysfunction, patients with some types of diabetes and distal tubular renal tubular acidosis, like a type 4 renal tubular acidosis. Look at the diet of the patient. Is he taking enough more fruits, more fruit juices, more nuts? These are certain things that we miss. Strict potassium restriction diet, reduce the MRA, or even you can omit the MRA for the time being. Can we change to the new drug Finrinone, which is little more potassium friendly? We don't have a data in heart failure. Basically, the data is in renal dysfunction. But judiciously, I think we may change to Finrinone. It's the same group of drug. And spironolactone is very potent drug. So you can change our spironolactone from eplerenone, which is a weaker drug, so that the potassium increase may be less. We don't have this drug, patisiran or sodium circonate, which is now the tendency for patients who derive benefit out of ARNI, and potassium is the limiting factor. You combine potassium with patisiran, potassium sparing diuretic with and ARNI with patisiran, so that potassium is not an issue for you. And these are the cutoffs which I have already discussed. AZ inhibitor, ARB, systolic blood pressure should be more than 100, EGFR 30, and potassium should be less than 5.4. Look at the symptoms for postural hypotension, creatinine, potassium, and we may reduce or discontinue if this increases, especially increase in creatinine by more than 30% in a month's time. So early rise in creatinine, as I said, is an anticipated effect. Remove the other drugs and all. Beta blocker, better to have the heart rate of more than 60 beats per minute and a systolic blood pressure of more than 100. We don't have any laboratory parameters to look at the beta blocker effect. It is heart rate and systolic blood pressure. Better reduce the dose if the heart rate goes less than 50 beats per minute. MRA, again potassium, 5.4 is the cutoff. Up to 5.5, okay. Increase in serum creatinine more than 30% within 4 weeks of initiating, we may have to cut down the drug. SGLT2 inhibitor is very friendly drug. EGFR up to 20 with empagliflozin. This also produces an early rise in creatinine, which will settle later, and look for genital mycotic infection. I'll tell a word about the use of diuretics. Patients with significant congestion needs decongestive therapy, no doubt. Their creatinine will rise, their blood urea may rise. Usually it settles. And renal vein congestion is there. Relief of the renal vein congestion and the renal edema helps the renal function to improve. So increase in creatinine during diuretic treatment is common and do not always necessitate stopping or decreasing the loop diuretic dosage, especially if the congestion is persistent. There is data which says that if you discharge the patient with persistent congestion, these patients are going to come back with heart failure hospitalization again. And the clinical data suggests that these changes in the creatinine are usually transient, associated with the similar or even better long-term outcomes in the setting of effective decongestion. Then with the heart rate, the patient needs beta blocker. He has some amount of left bundle branch block. Or if he requires a pacemaker and you want to continue beta blocker because the heart rate is coming down, you are not able to start the beta blocker, put in a pacemaker, and better to go for a CRT rather than a pacemaker alone because you may need upgradation later. This helps to use beta blocker safely in those with bradycardia. And borderline blood pressure, if no symptoms, GDMG should be continued. And both the drugs, ARNI and MRA, may be permitted with potassium up to 5.6 millimoles per liter under proper surveillance. Look for renal artery stenosis if there is a sudden deterioration in the renal function with RAS inhibitors. And change to eplerenone if gynecoma stay with spironolactone. And bronchospasm is the problem. Continue the beta blockers, shift to the bisoprolol, which is the most selective agent, especially carvedilol is a non-selective agent. It may induce more of the bronchospasm. And take the help of the pulmonologist, put him on aerosol bronchodilators and continue the beta blockers. Never ever discontinue the beta blockers. And for genital mycotic infection, you can suggest even a circumcision for the males and continue the SGLT2 inhibitors. So to take home, side effects are common with heart failure medications, especially polypharmacy. It's more in elderly, frail and CKD patients. Try your level best to continue the GDMT. Since it prolongs life, it improves the quality of life. Meticulous control of the fluid, food, drug dosing, concomitant medications. This will help us to continue GDMT. Discontinuation may be required in 2 to 4% of patients, not more than that. And sometimes we may have to discontinue the drug, which is required due to the life-threatening side effects. Thank you.
Thank you, sir.